Welcome to the National Ovarian Cancer Coalition's 2024 Fall Online Wellness Symposium. Our last session will focus on tonight Beyond the Diagnosis, Understanding and Managing Low-Grade Ovarian Cancer. I'd like to take a moment to sincerely thank our symposium sponsors who are dedicated to providing learning opportunities and programming for our teal community. Thank you so much to Northwell Health, GSK, AstraZeneca, Merck, Veristem, and Asai. It is now my pleasure to introduce everybody to our guest speaker this evening, Dr. Rosario, Gynecological Oncologist from Northwell Health.
Good evening, everyone. My name is Dr. Joan Rosario, and I'm a practicing gynecologic oncologist currently here at Northwell Health. Prior to coming to Northwell, I trained at Albert Einstein in residency in New York, and thereafter completed my fellowship at Yale. I've been very fortunate in my career thus far to really work on translational projects that target patient-specific molecular profiles and provide them with a targeted approach to their cancer diagnosis. And I treat patients with gynecologic malignancies, so that's cancers of the uterus, cervix, vagina, ovaries, or fallopian tubes, as well as the vulva. So of the reproductive organs of a female. Since being here at Northwell, I've also had the privilege of being part of the SGO Bridges inaugural class that bridges the gap between bedside preclinical research and translational research that's provided to the patients. And tonight, I'm fortunate to be here to talk to everyone about a very important topic that's near and dear to me in the care of my patients. And that's beyond the diagnosis, understanding and managing low-grade serous ovarian cancer. So to give a little bit of a background, compared to high-grade serous ovarian cancer, which is typically a more aggressive variant and a more common variant of ovarian cancer, low-grade serous carcinoma is, again, less frequent and is poorly sensitive to chemotherapy and other systemic treatments that we have for women. And unfortunately, it affects younger women, many who endure years of ineffective treatments and, as a result, poor quality of life. And the pathogenesis and its management today still remains incompletely understood. However, we are gaining much information as we come along. And today I really want to go through understanding this pathogenesis that we understand so far about low-grade serous ovarian cancer and how it's different from that high-grade ovarian cancer, review the basic clinical presentation, diagnosis of this disease, and treatment modalities that are available, and to understand the impact of these treatments on patients. In particular, again, them being mostly young patients, how do we treat surgical menopause symptoms and what options are there in regards to fertility preservation? And then I'd also like to discuss newer treatments on the horizon and some exciting clinical trials that are currently available and to come as well. And then I also want to review the disease process from the patient's perspective. I look forward to a discussion and sharing questions afterwards in our virtual platform. So just a brief background, ovarian cancer is the second most common gynecologic malignancy of the ones that I have mentioned that we treat as gynecologic oncologists, but it is the most common cause of cancer death from the GYN cancers in the US. The most common type of epithelial ovarian cancer subtype is serous, and 90% of these serous cancers are what we call high grade, or what we consider a more aggressive variant, and 10% are of the lower grade. And low-grade serous cancer appears to exist of what we think of a spectrum. So we think that there are precursors to these cancers, such as borderline tumors or these precancer precursors. And they have distinct pathology, where our pathology doctors look at it under the microscope and can see that there's a difference in these biologies. They also behave differently than the high-grade types, and the prognosis is very different compared to the high-grade ovarian types. So as I briefly touched on in the other slide, low-grade serous ovarian cancer can form de novo or sporadically, or it can originate from a borderline tumor. And borderline tumors are not considered invasive or cancer, but they are this precursor, now we know, for these low-grade serous ovarian cancers. We also know that low-grade serous ovarian cancer is poorly sensitive to chemo, and as I had mentioned, it affects younger women. And because these women have good performance statuses or they're very healthy, and because this tumor typically grows slower, again, everyone's disease is different, but typically it grows slower. And if you get remission of your disease, it tends to come back often at later times than the high-grade serous type, or in longer intervals of time to recurrence. And as I mentioned, we're really, now that we've entered the era of molecularly targeted treatment and really understand a lot about genomics and tumor profiling, we are understanding more about this tumor process, but there still remains a lot unknown. And recent advances in this molecular characterization of the disease has allowed us to provide better treatment options and the hope for better outcomes for our patients. So low-grade serous ovarian cancer is classified as a rare disease. So it's one of those diseases that affects less than 200,000 people in the US. And it is so rare that there are not good prevalence estimates. But we estimate, as I had mentioned, that it consists of 10% or less of the epithelial or the more common types of ovarian cancers. And again, while the other high-grade variant of ovarian cancer is associated with these BRCA-associated etiologies or these genetic predispositions, we don't consider low-grade serous to behave in that same fashion, and it has a different tumor biology or molecular profile. The risk factors for this disease, again, because it is a rare disease, it's difficult to get good data on the actual statistics. But there is a retrospective Danish study that has some good data that looked back on risk factors, and risk factors that are thought to be associated with a lower risk of serous borderline tumor, which is a precursor to low-grade serous cancer, were found to be parity, older age at first birth, and oral contraceptive use. And then risk factors that increase the risk of these serous borderline tumors or increase the risk potentially or theoretically of low-grade serous cancer are infertility and hormone replacement. And that infertility may be a surrogate for perhaps having received hormonal treatments during the infertility. But again, the data or the quality of the data is not high, but it does give us some insight into what we know from patients who've had the disease. And additionally, the rate of BRCA mutations in those patients with low-grade serous ovarian cancer range from 0 to 5%. So it's not very frequently found. And we typically consider it not to be a BRCA or BRCA-associated cancer. However, our national guidelines, both ASCO, NCCN, SGO, does recommend that all patients with epithelial ovarian cancer, so whether you're low grade or high grade, receive germline genetic testing. And germline genetic testing is essentially testing that can be performed in your provider's office, whether it be a gynecologic oncologist, medical oncologist, or genetic counselor. And the team member will provide the test either via saliva or blood draw, and it will tell you if you've inherited a genetic mutation. So these germline mutations are inherited mutations that are passed down from your family. They're not mutations that are just found in the tumor like somatic testing. And as I had mentioned, all patients with newly diagnosed ovarian cancer should be offered, and it should be covered, or the fee will be waived by the companies that send them out. The National Comprehensive Cancer Center also recommends somatic testing in the initial diagnosis setting. So somatic testing, as I had alluded to, is testing of the tumor and its genetics. And while the tumor could have BRCA mutations, it will have other mutations that the tumor has acquired as it abnormally proliferates. So that gives us more information into the type of mutations the tumor has and potentially what targets we can treat against to provide patients with more personalized treatment. Mutations that we have found through somatic testing, in particular to low-grade serous ovarian cancer, and ones that we at minimum recommend testing are KRAS, HRAS, NRAS, BRAF, NF1, and BRCA alterations. And reasons to repeat testing throughout a person's disease process include if they have recurrent disease and disease that is acting different than we would expect for a low-grade tumor type. So if it's progressing more rapidly, it has recurred more early than we would anticipate, or if it's not responding as we would think to treatments that we usually provide. And the reason why this repeat testing is important is because the tumor can undergo transformation. And although rare, it is possible that the low-grade tumors can transform into high grades. And I have seen that less than a handful of times in my career for this rare disease. So again, as we had previously mentioned, up to 60% of low-grade serous ovarian cancer originates within this borderline tumor precursor. And then that really has established this continuum between transformation of the borderline tumors into low-grade serous ovarian cancers and supports this developmental relationship. Over the years, there has been a change in terminology, and this terminology is between the definition of different types of that spectrum between borderline and the invasive disease. We realize that we need to be more universal and have acceptable definitions amongst providers so that we can provide standard treatment options. And so there have been strides to make the definitions of the diagnosis standardized, as well as to decrease the difference between different pathologies reading what the tumor actually is defined as. And that those definitions and further molecular testing have supported that again and again, these low-grade tumors are distinct and different from the high-grade tumors. But not that they can't coexist together, not that there can't be transformation, but that is a more rare process. And often this continuum of transformation, when you do genetic testing on the tumor, you can see that there are acquired mutations within the KRAS, BRAF, and NRAS pathways that demonstrate that there is this continuum relationship. Another major pathway that is affected is the MAPK pathway, and it is prominent in approximately 50% of low-grade serous tumors. So when looking into molecular targets to treat these tumors, this becomes an attractive pathway to alter or to inhibit to hopefully get some therapeutic response in the treatments. And then similar to this MAPK pathway, there are other mutations, as I had alluded to, the KRAS and BRAF that are also prominent in about 50% of tumors. And then just to provide and be comprehensive, there are some other alterations that are listed here. And now that we know about these alterations and their prominence within these tumors, it also provides us with some information to compare the biology of different patients' tumors. So, in fact, this MAPK alteration is associated with an improved prognosis for patients. So again, letting us learn more about a patient-specific disease and how their cancer may behave, and just really trying to learn more about this disease process. How is this cancer diagnosed? It is diagnosed Similarly to the high-grade type, essentially you need tissue diagnosis, and that's usually obtained after surgery, so that some tissue, whether it is the ovary or a full staging specimen that is removed from the patient's body and tested by our pathology team, and molecular testing is also performed as well. And the definition per WHO that we've universally made is that it is an invasive serous neoplasm with low-grade malignant features. And when the diagnosis is made, and if feasible, based off of evaluation with your doctor, that's typically a gynecologic oncologist, they will evaluate you for primary surgery, and if deemed a candidate based off of the amount of disease and the patient's health status, they typically try to recommend surgery just upfront to understand both the stage as well as to remove the disease that they can visibly see with their eyes. In regards to biomarkers, I did talk a little bit about the pathogenesis, the biology, and while we know more than we did before, their optimal biomarker for the sensitivity of this low-grade serous ovarian cancer to therapies that we have available, such as endocrine therapy, is unknown. So for instance, estrogen positivity on a tumor, theoretically, it makes sense that if the tumor is estrogen positive, then the patient might be more likely to respond to hormonal therapy. However, regardless of positivity, we still do see benefit in patients who are hormone receptor negative. So we really have to understand a little bit more about that and the pathogenesis behind that. And additionally, we see some patients that are hormone or estrogen receptor positive, and they don't respond as well to hormonal therapy. And some theories we have to that reasoning is that the tumor might have other alterations. For instance, we know of one of them, an ESR1 alteration. And we understand that that might be happening and maybe conferring resistance to aromatase inhibitor therapy, which is one of our most frequently used anti-hormonal treatments, because of evidence we have from other diseases that are more common, such as breast and uterine cancer. This is just a slide if there's any interest in regards to the exact definition. I know historically some patients' pathology reports might have different terminology for what now we have universally defined as low-grade serous cancer, or maybe they might have now fit into the more borderline category. But this slide just nicely shows that there is this pre-invasive or borderline serous tumor. There is the older terminology of micropapillary serous borderline. And then there is still borderline tumors with non-invasive implants that are not low-grade serous cancer. And even though these are non-invasive implants, it's still not considered the cancer or the low-grade serous cancer unless those implants have the cancer within them. So it can be a little bit tricky. Again, this is just to be completely thorough and provide the information. But the nuances, if there's any patient questions regarding this, can definitely be discussed further with your G1 oncologist. So treatment. Ovarian cancer, whether it be high grade or low grade, is surgically staged. And the process of evaluation for surgery, or the preoperative evaluation, is made with the patient and their surgeon or their G1 oncologist. So your surgeon will evaluate you for the extent of disease. That's typically performed with a CAT scan of the chest, abdomen, and pelvis. They will also draw a CA-125, which is historically what we do to assess chemically, perhaps the extent of disease, with high elevations correlating to be significant of more extensive disease. However, we're really extrapolating that information from the high-grade ovarian cancer. For low-grade ovarian cancer, that may not necessarily be the case, but currently we don't have a better marker, so we use what we know and what we've done more often for the high-grade tumors until we find something better, and I'm sure we will. Other things to assess is to assess the patient's health and ability to undergo a big surgery, if that's indicated. So you assess their age, you assess their medical comorbidities, and assess their ability to recuperate from the surgery, and that and not to affect their quality of life too much. And for the rare patient where primary surgery or comprehensive surgery cannot be performed at that moment, either due to just a vast amount of tumor where we feel like we can't resect it safely, or the presence of disease outside of the abdomen and pelvis, such as in the chest or the head, we do offer what's called neoadjuvant chemo. And that is typically chemo that we use to shrink the disease and then hope at a later time after a few cycles to go back and surgically remove everything. So while historically for high-grade cancer, the more common cancer, we more frequently offer this approach because outcomes are not different. I would say for the low-grade ovarian cancer that we really try to offer surgery upfront, even if it doesn't seem like it may be feasible, as long as it is deemed safe for the patient. We do really try our best to offer surgery upfront because the chemotherapy that we give for the high-grade types that works 80% of the time does not work the same way for low-grade serous cancer. So if we can really surgically remove everything, we are giving our patients the best shot. Again, not always feasible, but we really do try to do that. And often we work in an interdisciplinary team. If we have to call in urologists or colorectal surgeons because the surgery is going to be that extensive, we do try to provide our patients with those options. So for patients with not as advanced disease, so such as stage 1 disease, or early stage confined within the ovary, or again, an earlier stage process, we offer comprehensive surgical staging. If the patient is done with childbearing, this would involve the hysterectomy, so total hysterectomy and removal of both tubes and ovary, as well as assessment of the peritoneal cavity, the lymph nodes, and the omentum. In younger patients, which this disease very much affects a younger patient cohort, patients still want fertility. So fertility-sparing surgery is a safe and viable option, especially if there's only one ovary involved. But again, that's a shared decision between the patient, the provider, and the patient's actual disease process on evaluation. There's not great data to provide us on information about surveillance after a fertility-sparing approach, and how we monitor the other ovary and the timeline to do so. I would say safe options that a lot of gynecologic oncology providers do with their patients is surveillance with a sonogram and CA-125, as well as physical exam, and monitoring closely in the beginning every 3 to 4 months, spacing it out to 6 months, and then yearly. And then if they're done with fertility, considering definitive surgical management at that time if needed. And also weighing risk benefits of early menopause. So it is a detailed conversation between the doctor and the patient in regards to timing and treatment. In regards to oocyte retrieval and infertility options, it is considered a safe option if the patient has an unaffected contralateral or other ovary to provide oocyte retrieval. In this case, I would collaborate with my reproductive endocrinology colleagues or IVF doctors to help provide that option. And there are safer options that we use in other cancer survivors that have hormonal positivity, such as breast cancer patients, where we can provide different gonadotropin treatments and letrozole during the treatment to stimulate, so it's not as estrogen stimulating, and those have found to be safe in these patients' populations. Treatment for the more advanced stage, so stage 2 to 4, again, typically involves the maximum cytoreductive surgery that we had mentioned earlier. So it really means going in there, having an open surgery, and removing anything that the surgeon can visibly see with their eyes. And that might require bowel resection. It might involve a pretty extensive surgery. And again, just because systemic chemotherapy and current treatments that we have don't work as good as they do in other types of ovarian cancer, such as a high-grade type, it's really important to try to surgically remove everything if we feasibly can. And there have been many studies to demonstrate that complete resection to no gross residual, and that's just a medical terminology again to say we've removed everything we can see with our eyes grossly from the patient's body during surgery. That has been associated with prolonged survival. So whether it's progression-free survival or that time frame to when recurrence might happen, or just overall survival in general has been much better with surgery that has achieved such. And again, the reason being is because unfortunately this disease does not have a good sensitivity to chemotherapy. And so when faced with a diagnosis like this, it's really important for patients to meet a gynecologic oncologist, maybe meet a few of them, really get all the options spoken to you about, and really to consider surgical debulking. And maybe there might be a team of surgeons that might need to be involved to help deal with this. Neoadjuvant chemotherapy, and that's the chemotherapy I had mentioned that you give before surgery to hope to shrink the tumors and then go back and surgically resect in a more safer fashion. That, again, is more frequently done in the high-grade type. But again, due to maybe patient comorbidities and a very high burden of disease, it might not be feasible or safe to do surgery up front. So then we do try new adjuvant chemotherapy. And as we had mentioned over and over again in this talk, just because chemo doesn't work as well in this group and they're relatively chemo resistant, we have tried different studies using different treatments, so different anti-hormonal treatments and combinations of such that have showed more promising ability to decrease the tumor size and then get to surgery and make it safer. But again, there is more work to be done, more studies to show the feasibility and safety of this, but it does present an option, and this is where also clinical trials come into play to provide these patients options on novel targeted treatments. And prognostic factors. So as I was stressing, surgical management being important and removing as much disease as possible. So any disease left behind puts you at higher risk for the tumor to potentially come back. So really, truly removing everything you can at surgery is very important, in particular for this disease. And patients who are diagnosed at a younger age, unfortunately, from what we have seen so far, do have a poorer prognosis. Could that be because maybe they have longer time for it to come back and more chances? Could it be their tumor biology in general? We still have more to learn about that. And then, as I mentioned earlier, a MAPK alteration is associated with an improved prognosis. Adjuvant treatment. So this is treatment after you have had some surgical management. And it's more of that sort of preventative treatment or that treatment to decrease the chances of this disease from coming back. So for the low-grade cancer patients, we know that there's a lower sensitivity to the chemotherapy that we've traditionally given to the high-grade patients. And typically when you have a high-grade cancer diagnosis, we give this treatment to prevent it from coming back because there's such higher chances of it coming back. When we try to extrapolate this to the low-grade patients, it doesn't exactly provide the same benefit. And NCCN, or our national guidelines here, and the European guidelines represent the current standard of treatment for our patients, which are surveillance is generally recommended. So observation with close follow-up with your doctor is recommended for those with stage 1A or stage 1B disease. For those with stage 1C disease, there's a series of options. So this is where there is extensive discussion with your doctor and where we may see different treatment patterns happening across different patients' disease biology and their specific case. So some doctors may recommend observation for these patients. They may recommend the traditional chemotherapy that we've given for adjuvant treatment in the high-grade types, which is the carboplatin and the paclitaxel. Or because some providers, understand that this systemic chemotherapy doesn't work the same way in high grades, we try to provide them with endocrine therapy instead. And then there are ongoing studies, and I encourage enrollment in such for us to better understand and to help patients in the future. There are options of giving the systemic treatment or the systemic chemo followed by endocrine treatment, and then comparing it to maybe just endocrine treatment alone. So we're really trying to understand what is the best treatment algorithm. So there is some opportunity here for there to be improvement, of course, and also for there to be variability in suggested treatments to patients. This is a illustration of what I had just mentioned. Again, that early stage 1A to 1B. If we've done surgery, we consider observation to be the best option. And the way we find out these stages is after surgery's been done, the pathologist evaluates it, and that is what determines the extent of disease in this stage. For stage 1C, as I had mentioned, there's the observation option, the anti-hormonal option, and there is the systemic treatment option. And there is just a few different types of different regimes that we can offer patients just based off of toxicity profile and further discussions with the patient about the importance of that and how it may affect their quality of life. For the more advanced disease, it also involves surgery, as I had mentioned, usually the bigger cytoreductive surgeries. And following those surgeries, just because there is a higher risk disease and because we extrapolate off of what we know a little bit better, being the high-grade types, we typically offer the adjuvant carboplatin and paclitaxel treatment for 6 cycles, followed by the anti-hormonal or endocrine therapy, or just endocrine therapy monotherapy alone. And again, this is also another area of investigation actively, and where you will also see variability in treatment plans. There's a lot of information out there about different novel approaches to providing intraperitoneal chemotherapy at the time of surgery, or dose-dense chemo options, or hyperthermic or heated intraperitoneal or in the belly cancer at the time of surgery. There has either been demonstrated no benefit to this in the high-grade serous ovarian cancer type, and it's typically not recommended outside of a clinical trial, whereas it's a different scenario for high grade. Also, to summarize what I had just mentioned, again, there is some opportunity for differences in treatment care that your provider will offer you based off of your risk factors and your stage of disease, and patient considerations of quality of life. So typically after the higher, more advanced treatment, we do offer something, whether it be anti-hormonal treatment alone, chemo, and then anti-hormonal treatment. So these are the various different systemic treatment options that can be provided to you, and again, have a little bit different symptomatic profile based off of the patient's wishes and or any other diseases they may have. So hormonal therapy is not well defined in the guidelines. We acknowledge that there is work to define this better. We do have ongoing studies to help clarify that. There is some information we do know about anti-hormonal or hormonal therapy, is that aromatase inhibitors appear superior to tamoxifen. This is different from breast cancer. And we do have some evidence in trials to support that. And additionally, as I mentioned, there is a study ongoing. There's NRG-GY019. It's part of the NRG rare tumor trial bundles. And it really is focusing on trying to answer this question for our patients with this rare tumor. So whether hormonal therapy could be used alone after surgery, or is it better to receive the chemo and the hormonal therapy? So that's ongoing and it's enrolling. And it really will help us answer this question in the future to help guide our patients and their treatment. Monitoring or surveillance. So this is after you're done with your treatment, which may be any of the algorithms we just discussed. And if you have early disease, you are going to be monitored in a similar fashion to this, and as opposed to the higher stage diseases, they are also similarly managed. And this includes routine imaging in conjunction with the CA-125. The imaging typically is done if you have symptoms and there's concern that there may be disease recurrence, and that typically is in the form of a CAT scan. And importantly, if you have higher risk disease, it could be on a monthly interval and then spacing them out over time. And then earlier at any point if you find that there's concerns for relapse. Additionally, the follow-up includes close follow-up with your doctor and physical exam to make sure that there's no concern from that standpoint in regards to symptoms or a physical exam findings that there's a recurrence. And additionally, one of the unique things to this disease process is that patients are often younger at diagnosis and may be brought into menopause surgically earlier. And they may also, in addition to that, be on anti-hormonal therapies such as aromatase inhibitors, all of which increase the risk for osteoporosis or more likely to have issues with bone health in the future. So it's important to also include bone mineral density testing in the surveillance, as well as talk about other risk reductive strategies and lifestyle interventions to help with bone health, such as dietary modifications, vitamin supplementation, and exercises, such as weight-bearing exercises. So management of recurrent disease. So this is disease that occurs after you have completed your initial treatment. You may be any amount of time after during surveillance. And typically, in these cases, unlike the high-grade serous ovarian cancer where we do have chemo that often is effective in this scenario, we don't have that for the low-grade serous patients. So we do try to offer them surgery again if feasible and safe. And not only do we recommend it if it comes back the first time, but on any other subsequent time, if we can do surgery, it still may have proven clinical benefit in this scenario. So that's different than other types of ovarian cancer where we really provide systemic treatment and targeted treatments in this setting. And along that line, the reason we try to provide surgical management at that time is because if you look at the response rates based off of the treatments that we have, they're unfortunately very low. So for systemic chemotherapy treatments, which are in the first three rows here, it's anywhere between 0 to 15% at best. And the anti-hormonal treatments don't appear to be much better, right? Letrozole up to 14% response rate. And trametinib and binimetinib, which are more newer treatments, do offer light for being a more improved response rate, but still 16 to 26%. But again, we do take these treatments to be options. They're encouraging to provide us to seek more further options. And other options that I've listed here on the right are MEK inhibitors, dabrafenib and trametinib, for patients who have BRAF V600E positive tumors. There's ongoing trials that have showed so far very promising results. And again, the hormonal treatment, the aromatase inhibitor appears to be better than the tamoxifen, as historically shown. We can provide chemotherapy that I have shown here on the left as a few, and then add an immunotherapy plus as bevacizumab, or we can give that immunotherapy bevacizumab as a single agent. One of the things to keep in mind with the immunotherapy bevacizumab is that we try to use it earlier on in the disease recurrences, because if there's concern for bowel obstruction or tumor that is blocking the bowels, it's a contraindication to using that treatment because it could put you at risk for bowel perforation. So, as this disease often comes back and returns in the abdomen and the pelvis, it often predisposed patients to bowel obstruction. So again, we have some better options that are coming out. We have things that are under investigation that are showing more promise. We have clinical trials coming out to answer some of the unknown questions. And we have clinical trials coming out to target patient-specific mutations. So, for clinical trial enrollment should be considered and discussed to all of our patients with low-grade serous ovarian cancer, because it could shed an opportunity for hope and an opportunity to give them better treatment with a better quality of life, and then also to understand more about the treatments and hopefully help other patients in the future as well. This is a very busy slide. I understand that. I just wanted to also be thorough. I wanted people to understand that because we're smarter now about tumor biology and biomarkers, that there are some biomarker-driven treatments and options, some of them being NTRK fusions, some of them being DMMR or TMB, all of which are markers of sensitivity to other immunotherapies, such as pembrolizumab, dostarlimab, or durvalumab, which have recently been FDA approved in other cancers. I would caution, though, that within the low-grade serous ovarian cancer tumors, that those mutations for which those immunotherapies can be options do rarely happen, but they can happen. So it's important to know if a patient's tumor has one of those things, we do have these options for them. And again, folic acid receptor expression for mirtuximab is also an option in ovarian cancer in general. And then, as we discussed, the BRAF V600E mutation. In regards to emerging treatments, this is a slide dedicated to demonstrating all of the various different targeted treatments we have. And this includes providing targeted hormonal treatments, RAF/MEK inhibitor treatments, CDK4/6 inhibitor treatments, various treatment algorithms that are targeting specific tumor biologies or molecular targets for a patient, and are going to provide us more information on how they may benefit the patients within the trial and generations to come. So all trying to improve the disease outcomes and hopefully, while these treatments do have their own side effect profiles, mitigate providing patients with systemic treatment that we know doesn't work as good and has side effects that significantly affect patients' quality of life. Because the toxicity profile of the newer treatments are being learned about, and we know more and more about them each day, especially as providers in ongoing clinical trials, it's important to understand the newer ones because they're not typically the hair loss or nausea, vomiting that we would associate with regular systemic chemotherapy that patients and providers are used to. But with some of the targeted treatments, there are newer reactions such as rashes, diarrhea, cardiac or eye issues. So it's important for your provider or your doctor to understand what these side effects may be, to discuss them with the patient so that they're aware and they know what preventative measures to do to prevent them. And awareness and management, and when a patient says that they're experiencing these issues, to really take them seriously and to be ahead of anything getting worse, and always to, again, try to make this the best quality of life for our patients. So I know that was a lot of information, but I wanted to just kind of take it all back, summarize it, really drive home some key points. So low-grade serous ovarian cancer and treatment options is an unmet need. Why? It's our younger patients. They present with advanced disease, and we have few options that are really good. While we are working on making it better, we still have a ways to go. And there are currently no FDA-approved drugs or treatments specifically for this disease. So even further highlighting the importance of the clinical trials and our need to work on that to get more clinical trials and to present these options and make them available for our patients. And I know I talked a lot about pathogenesis and molecular biology and treatment options, but I think it's really important to take it back to the patient and to understand where they're coming from, and really to have them involved in every aspect of their own care. Because the whole reason we're doing all this is for the patient. So I think it's important for us to identify the concerns and experiences of patients, all the patients with their cancers, and in particular to this different patient cohort with a rare disease, to understand where they're coming from, to allow us as healthcare providers and researchers to better address their needs and to improve their quality of life. So a series of questions was posed to participants in large social media platforms. And the survey involved quite a few patients, and it's giving us insight into what they have to say. And again, this is not totally comprehensive in any regards, but it gives us insight into what the patient's feeling and how we can better treat them. So what did this survey say? So when we asked what are the most important issues to women that are diagnosed with low-grade serous ovarian cancer, treatment options were important to them, knowing where to find accurate information and resources. And with that, knowing where to find resources for emotional and psychological support. Also understanding their fertility options, and if that may be an option, which it very well may be in this disease process. Opportunities for learning about financial assistance as we are learning more and more and providing comprehensive care to our patients, understanding the financial toxicity associated with the diagnosis. And understanding more about their disease, understanding the difference between the more common high-grade ovarian cancer and the low-grade serous type. What are their risks of recurrence? Understanding the side effects of their treatments and being proactive to prevent such side effects. And understanding updated statistics and research. A lot of the outdated discuss the tumor biology and molecular profile of this tumor, which we now know a little bit more about. And then should prognosis be discussed with our patients when they're diagnosed? The good majority said yes. So some proponents of saying yes express the benefit of planning and quality of life, do all of that. But those who said they were unsure expressed the fear of knowing the answer, which is human nature. And recommending approaching, and across the board, they recommended approaching the subject with sensitivity and avoiding population statistics to really treat your patient, their prognosis, their disease, their experience to them. And what other factors would influence your willingness to take part in clinical trials? Education is key. The greatest factor that influenced patient participation was merely being asked to participate, to understanding that it's an opportunity, to understanding what the options are and what this newer option may pose to them. Other factors, which are often the reality of treatment in general, is the availability to get to a site with the trial, the time and cost associated with that, accessibility, and of course, the potential concern of the unknown of the adverse effects with the treatment, their quality of life while on the treatment. So it's really important to discuss risk benefits thoroughly. And then also to understand that while on trial, yes, some risks may be unknown and we learn about it as it goes on, but everyone is very closely monitored. And understanding to the patient of whether chemotherapy is required in their disease process. Some things that we might take for granted, just really thoroughly discussing all of the options and what their life may look like with them. And then what are the best resources for patients to connect with each other and to gain information about their disease? I think tonight's platform is a great opportunity, and the National Ovarian Cancer Coalition is amazing and proactive and is a great platform to discuss everyone's different perspectives, whether it be patient to patient, patient to provider, everyone together. There are other amazing organizations, Cure for Ovarian Cancer, Star Ovarian Cancer, NCCN, and some of the guidelines I discussed throughout this presentation has patient-centered resources. There's the Ovarian Cancer Research Alliance. There's good old Facebook and group chats where patients come together. And there are a lot of charities, foundations, and organizations dedicated to this matter. And is there anything else that you'd like to say? And I'm not going to leave this with just this slide. I'm willing and happy to hear what everyone else has to say here tonight, but patients do ask that their physicians or their provider take the time to listen to them, that they have a good attitude, that they are compassionate, empathetic, and honest with them, but they are also informative and they take the patient serious, and especially when it comes to adverse effects and how they're affecting their quality of life. And another aspect, given that these are young patients, and often the disease isn't as fast growing or as aggressive as the other ovarian cancer types, the patients are living longer. And our survivors are out there too. And sexual health and vaginal dryness for these young women who have been through treatments that very much affect this aspect of their life is important to talk about. And then not only better diagnosing, better treatment, but better testing for recurrence is an unmet need. And if the imaging modality is suggested, patients do prefer ultrasound to other modalities. And then I love to invite questions, and I thank you all for being here and taking the time to listen and to be part of this presentation tonight. Thank you.
Dr. Rosario, thank you very much for guiding us through this very meaningful discussion. And this is a lot of information for people to process. And I want to take a moment to say that these programs are made possible for us by our dedicated sponsors, such as Northwell Health, GSK, AstraZeneca, Merck, Verastem, and Asai, because they want to provide learning opportunities and programming for our teal community. We want to help you help you with information to help you make informed decisions, shared decisions with your healthcare team. So, Dr. Rosario, this is a very complicated topic of discussion. And to reiterate again, when somebody is diagnosed with low-grade ovarian cancer, is it that chemotherapy is not an option at all, or is it that just that it does not work as well as it does for high-grade serous ovarian cancer patients?
Yes, so it is for sure an option depending on the stage of your disease and the concern for it to return. So the more advanced stage, the stage 2, 3, 4, that you may have undergone a big surgery to remove all of the disease, to hopefully no residual visible disease, there's a high chance of that coming back. So we don't sometimes feel comfortable just saying, let's do observation. We want to do something. So while we don't have good studies yet that are completed to demonstrate, could we just give the anti-hormonal treatment, or should we give chemo followed by anti-hormonal treatment? We don't simply know that. We know that patients do respond sometimes very well to just anti-hormonal treatment. Sometimes they don't. And some patients, because of the high-risk nature of their disease and the high-risk recurrence, and you counsel patients on the risk benefits of treatment with chemotherapy, knowing that it may not work as well as the high-grade tumors, it's still an option for them, and it's still a recommendation sometimes. But again, you have to meet the patient where they are, given this unknown of it being less likely to work than the high grades. Do they want to incur the side effect profile to that? And they may not. So in those patients' options, hormonal treatment or anti-hormonal treatment is another option. Or going on clinical trial. Yes, you will be randomized to one group or the other, but it'll give us more insight into knowing the safety of just doing the anti-hormonal treatment versus the triple treatment.
Very much for clarifying that for our audience tonight. Can you speak to the role of CA-125 in patients who are struck with low-grade ovarian cancer?
Yes. So we use CA-125 as a marker for epithelial ovarian cancer, concern for recurrence or assessing response to treatment. A lot of the data comes from looking at the most common type of epithelial ovarian cancer, which is 90% high-grade serous. So while we know a rising CA-125 or a lack of decline during treatment indicates that there's more tumor burden and it's not responding as much to chemo, in low-grade serous, the numbers might not be as markedly high, maybe because there's not as much rapid tumor growth or just because of the biology of the disease, but we often do see elevations that can inform us as to whether there's concern for recurrence when you're being followed or declines demonstrating that there's some response to treatment while we're giving it. So we still do use it. We don't have a better marker. There are probably better markers coming out that need to be tested. There is something called cell-free tumor DNA that's being assessed in all cancers across the board. So more to come in the future and to understand that. But for right now, CA-125 is our best chemical laboratory test we can use.
Thank you very much for that information. Another question that was put into the chat is the MAPK information in your original pathology report, or does it require further tumor testing?
It depends on your site. It depends on your pathology/laboratory system's ability to do that. I know here at Northwell and some other sites, they are having their own next generation sequencing platforms that are being run by the pathologists. But typically when that's not available, we do also send out tests like Foundation, Myriad, other testing platforms that are tested and trued and have these platforms to do the genetic testing. And all of those testings will be covered by insurances because this is a cancer diagnosis. It's not a pre-invasive or benign condition. So all of these things are suggested and recommended by all the societies, and it should be part of the standard of care for our patients.
Thank you for clarifying that point for us, and I hope that answers the audience's questions in regards to that. Again, speak to your healthcare team about the pathology report. What about, can you circle back to the topic of annual imaging and how it plays in the world of low-grade ovarian cancer? Is it recommended for all patients to continue with annual imaging or only if symptoms are presenting themselves?
So it's also and I am sorry to also be vague, it depends on the patient. It depends on their stage of disease, how far out they are from their finishing of treatment, whether that's just surgery or surgery followed by other treatments or other adjuvant treatment options. So if it's a low risk disease or early stage disease, I would tend more towards going by symptoms and doing the spacing out. If it's a higher grade disease, we can do it more frequently in the beginning and earlier if patients have symptoms.
Excellent. Show the slide where there's a lot of different clinical trials taking place for low-grade ovarian cancer. Are there specific doctors that people should be looking for when they are looking for somebody to be treating them if they are diagnosed with this specific type of cancer?
Yes. So across the board, I would say gynecologic oncologists. They're the providers that treat both surgically and with chemotherapy this disease process. Depending on the site, sometimes the G1 oncologist will work with a medical oncologist that will also help with their disease process. But because surgery plays such a big role in the management, more so even than high-grade serous, because we don't have great systemic treatment options, it's really important to at least have spoken to a gynecologic oncologist and to get their opinion on how surgery plays a role in their initial treatment and even the recurrent setting. So G1 oncologist, and then they will help guide you with their team on how they'll best take care of you.
Okay, so speaking of a team approach, when patients are dealing with some of the side effects of going through surgical menopause in the younger women, are there specific specialists that they could look to help guide them with dealing with the vaginal dryness that you spoke of? How does somebody seek out a pelvic floor specialist, for example?
Wonderful question. Actually, something that is also near and dear to my heart. Um, you know, another very important aspect of cancer care is survivorship care, and treatment after their treatments and during the surveillance time. So, I actually am starting a menopause intimacy and sexuality program here at Northwell, and me and some other providers who have an interest in providing special counseling beyond the surveillance visits and how to manage the symptoms of surgical menopause are working on that. And then we will also help provide referrals to, say, a pelvic floor therapist if they're needed in their treatment. But, I think every G1 oncologist should also provide this care. Where I was trained, we also had a very similar clinic that provided this for patients. Again, I think it's part of the 360 care in making our quality of life and really providing the best patient care experience going forward.
And it's about advocating for yourself, seeking out that other assistance, having that open dialogue with your healthcare practitioner. Can you share with the audience tonight, is there a length of time that you're allowed to stay on an aromatase inhibitor?
Also a great question. We don't have data to say, should we stop 2 years, 3 years, 10 years from now? So it is a shared decision. Again, if a patient incurs severe osteoporosis during their treatment and has other risk factors for a fragility factor, you may want to consider stopping it. Some patients may not want to because of fear of recurrence risks. So there is not a standard time to say when you should exactly stop. And it also depends their disease process. What I would say, you wouldn't stop it if somebody has active disease that you can see. I think we're more talking like after the disease is gone in a maintenance setting. We don't have a good time to say to stop it. But if you have disease that's active, it's indefinite until you can't tolerate the treatment.
Mario, you had mentioned that there is a lot of unmet needs in the world of low-grade ovarian cancer, but that other slide also indicated that there's a lot of hope on the horizon right now because of the different types of clinical trials. If somebody was interested in seeking out a clinical trial for their low grade, where would they look to find that information? Or who should they speak to on their team?
Great question. So, definitely talk to your GYN oncologist. We all meet pretty much at every institution in a sort of interdisciplinary meeting group with all of our oncologists, pathologists, radiologists called Tumor Board. And there we also bring up the options of clinical trials that are available at our institutions. If a specific clinical trial is not available at an institution, there is clinicaltrials.gov that will show you any clinical trial that is available, not only in your geographic area in the country and even in the world, and where they're enrolling and what sites. And NRG, GOG are big networks through which we often run a lot of these trials. So NRG is the group that is running the trial that I had talked about, testing the chemo and anti-hormonal treatment versus just the anti-hormonal treatment. So, if going on the website is a little overwhelming, which I understand it can be, especially putting in disease site and then treatment options, and then looking at all of the numerous amounts of information that can come up, first start with your provider. They can let you know what's actually available at their institution. If the patient's willing to look otherwhere, we usually know what institutions other trials may be available and try to help connect them. And often, going from one GYN oncologist to the other, they can quickly get the patients in.
Thank you very much for sharing those valuable resources with the individuals on our call this evening. One of the unique things about low grade is that it's slow progressing. If it is slow progressing, is there any way for somebody to gauge how long that disease may have been there before it presents with vast symptoms?
Disease as in recurrent disease, or disease that is initial primary diagnosis?
Primary diagnosis.
Hard to say, because we're not serially imaging individuals. And one of the unfortunate things, even high-grade ovarian cancer, is that ovarian cancer is often a silent whisperer. Like, patients don't really have symptoms until it's more advanced stage disease. So when it has spread out of the abdomen or pelvis and there's abdominal pelvic pain and there is cramping and there's swelling and there's inability to eat as much. So really education on understanding the signs and symptoms of when this may happen, and encouraging people to discuss this with their providers so they can do early workup. But there's not a time frame, say, from when you're diagnosed that you could say, oh, this started 3 months before, or this started a year before. And we can't even tell that with high-grade ovarian cancer. And we don't serially test patients for circulating tumor cells or things like that, or there hasn't been enough scientific validation to demonstrate that. So maybe in the future, but not right as of yet.
A clarification. And one other question from our audience is, it's slow growing, but what does that mean though when somebody does have a recurrence and they have a second recurrence right after their first, that it came back, say 2-3 months later? Is that a change? Does that mean it's now high grade, or it's still considered the low grade ovarian cancer?
Yes. So traditionally, we would still consider it, 90% plus of the time, it's going to be the same disease. We don't think that it's transformed. Not that it can't be. We can definitely repeat biopsy and do testing, but traditionally, we accept that it's the same disease process. So just because it's low grade, and we typically say that it's more indolent or it doesn't grow as fast or spread as fast as high grade, certain patients, for reasons that we're only starting to understand now about molecular biology, do still have poor prognosis or aggressive type low-grade serous ovarian cancer. So that time frame to which it recurs very soon is a poor marker for this being more of that aggressive type of low-grade serous. But if there is any doubt, especially in regards to it not responding to treatments and wanting to understand more about the biology of the tumor, as I said, very, very rarely it can have mutations that throw it into a high-grade type. So it's not unreasonable to get a biopsy, but it is most likely the same disease.
Okay, thank you very much for clarifying that question. And there's a lot of information that you had shared tonight. Very insightful. Hopefully people will be able to absorb it. I know it was a lot, but could you leave us on a positive note? If somebody just learned that they had low grade and they joined us for the first time tonight, what would you give them as a piece of advice if they were your patient?
Yes, so I would say every patient and their cancer is treated as an individual and unique tumor, that there is always the hope for cure. And the initial treatment is to provide them with that cure, whether it be through surgery, plus minus the need for some treatment. But we truly are understanding more about their disease and really trying to provide them with more opportunities to cure this and to live a good quality of life.
Thank you very much, Dr. Rosario. We really do appreciate your time and your insight tonight. I want to thank you and the members of our audience for joining us. And at this point, thank you all for coming.